based on all these particular parameters now. The clinical parameters, those are there. SpO2 we are taking help of, respiratory rate we are taking help of, the pneumonia that is there either with the help of CT scan or with the X-ray. We are taking help of the CT scan also, we are taking help of the laboratory findings also, including NLR, that is neutrophil lymphocyte ratio, CRP, ferritin D dimer, LDH, IL-6 and LFTs, taking help of laboratory parameters, HRCT findings and simple parameters like say SpO2 and respiratory rate. We can clinically categorize the patients into three important severity forms. One is the mild illness that is there, second one is the moderate illness and third one is the severe illness. We can categorize in this particular format. When it is a mild illness, it is a stage 1 disease. When it is a moderate illness, it is a stage 2 disease, and when it is severe illness, stage 3 disease. I will quote here one example. Let us take an example of the moderate illness that is there. What is this moderate illness? When the SpO2 is 90 to 94% in room air, when the respiratory rate is more than 24 but less than 30 per minute, when the pneumonia that is there, and the CT severity score that is there is between 9 to 15, that is a CT severity score to call it as a moderate disease. Laboratory parameters like say neutrophil lymphocyte ratio, when it is more than 3.5 but less than 5.5, then it is a moderate illness. CRP, when it is between 40 to 125, then it is moderate illness. Ferritin levels, when they are there more than 500, then again it is a moderate illness. So taking help of all these laboratory parameters, the HRCT findings and the clinical criteria, those are there, SpO2 requirement, we can really segregate these patients into a mild illness, moderate illness and the severe illness that is there. This mild illness, once it is categorized, can also be subcategorized in three forms. One is the mild illness where the patient is asymptomatic. Patient does not have any symptoms, but he or she is harboring this virus inside the body. In the throat, the virus is there. Asymptomatic patient that is positive for this COVID-19 test, either RT-PCR or say CBNAT or say antigen test that is there. Patient is absolutely asymptomatic, that is mild illness stage, mild illness A. Mild illness B, where the test is positive, the patient is symptomatic, but the symptoms those are there are mild symptoms. Fever, cough, breathlessness is not going to be there. There can be shortness of the breath, sore throat is going to be there, malaise is going to be there, loss of taste is going to be there. All these symptoms, mild symptoms are going to be there, but the patient does not have any comorbidity. Then it is mild B illness that is there. And mild C illness that is there, along with all these symptomatologies. When the patient has got comorbidity, then we are supposed to call it as mild C disease. So mild illness that is there can be categorized into A, B and C. A is asymptomatic, B is symptomatic mild but no comorbidity, C is symptomatic but comorbidity that is there. Another, the moderate illness that is there. Moderate illness can be subcategorized into two forms. One is stage 2A disease and stage 2B disease, that is called moderate. Very simple to remember. Moderate illness, when it is there, one thing is clear, that there has to be a pneumonitis. Could be a pneumonitis, HRCT score that is there beyond 9 but less than 15 that is there. X-ray chest is showing some zonal involvement, could be a 2-zone disease or 1-zone disease, but pakka one thing is sure, that pneumonitis is there. In 2A disease, along with pneumonitis, what is there is without hypoxemia. That means the patient's SpO2 is absolutely normal. It is more than 94, more than 95 that is there. Could be 96, 97, 98 and so on and so forth. In 2B disease, that is moderate illness and B category that is there, where the patient has got pneumonitis but there is hypoxemia. That means the patient has the SpO2 of less than 94%. Then we are supposed to call it as the moderate 2B disease. Moderate 2A disease can be a group D disease, it can be called as group disease, or 2B disease is group E disease that can be called as. And next variety that we come across is the severe illness. This severe illness really is a critical illness that is going to be there in this particular individuals, and it can be in the form of, one is acute respiratory distress syndrome. That means the lung is flooded with the inflammation and the patient has got dysfunction of the lung. The patient has got, is not maintaining the arterial pressure of the blood in the oxygen in the arteries. The patient is requiring the oxygen in oxygen treatment, and the PaO2 FiO2 ratio, what we call it as partial pressure of oxygen in the arterial blood, and the FiO2 that we are giving, oxygen that we are giving either in the form of 30%, 40%, 50% FiO2 that we are giving, we can really calculate the PaO2 FiO2 ratio, and we can really categorize this ARDS, what we call it as acute respiratory distress syndrome, in three categories. One is the mild ARDS, the moderate ARDS, and severe ARDS. The mild ARDS is going to be there when the PaO2 FiO2 ratio is between 200 to 300. Moderate ARDS is going to be there when it is between 100 to 200, and severe ARDS is going to be there when the PaO2 FiO2 ratio is going to be less than 100. This is very, very important to segregate the patient in the, or divide to classify the ARDS in this particular format, because the management strategy is going to be totally different when it is a mild ARDS, the moderate ARDS, and severe ARDS that is there. Another form of the severe illness that we are coming across is the septic shock, where the patients are having low blood pressure. There is evidence of sepsis that is there, clinical evidence or laboratory evidence in the form of either blood culture, urine culture, that means some organisms are identified, and the blood pressure, mean arterial pressure, is less than 65 millimeters of mercury in this particular patients, and to maintain the blood pressure of more than 65 millimeters of mercury, what is required is vasopressors, what we call it as septic shock, another form of the severe illness that we come across. And lastly, next form of the serious illness that we come across is the multiple organ dysfunction syndrome, where multiple organs are affected. The inflammation is here and there. Everywhere in the organs the inflammation is there. Not only the inflammation, because of this thing, the dysfunction of the organs is also going to be there. There is a myocarditis, say for example, the myocardial failure is going to be there. There is a hepatitis, the hepatic failure is going to be there. When there is a kidney involvement, nephritis that is there, the renal failure is going to be there. Acute renal failure is going to be there, MODS what we call it as. So these are various categories of the serious illness that we want. And who are the individuals ultimately? Who are the individuals who are going to land up with this particular severe illness? These are the individuals whose age is more than 60 years and certain comorbidities are there. I would like to highlight here the most important comorbid condition which makes the patient to land up into severe illness is the diabetes mellitus, right? And this diabetes mellitus can be the first time that can be identified once the patient is getting admitted. Patient doesn't know that the patient is suffering from diabetes mellitus, it is identified for the first time. Other comorbid conditions which makes the patient to go land up into a severe illness are the coronary artery disease, can be a CVA, cerebrovascular accident. Within the last 6 months, the patients are having history of heart failure, the patients of chronic obstructive pulmonary disease, whose the bronchial asthma is poorly controlled, systemic hypertension patients with the systolic blood pressure of more than 140 and the diastolic blood pressure of more than 90 millimeters of mercury. The patients suppose are having active cancer, the patients are having chronic kidney disease, decompensated chronic liver disease, somebody has undergone transplantation, somebody is on immunosuppressive therapy, somebody is morbidly obese with a BMI of more than 40, somebody has got hypothyroidism, and the history of epilepsy is there. All these are the comorbid condition. And why these comorbid conditions are required to be known to us? Because the patients are going to land up into a serious illness, and when the patients are having this comorbid, attention as far as the management of these conditions are concerned is also very, very important. And that too, the management of the diabetes mellitus is ultimately extremely important in this particular patient, because what has been observed is, as far as diabetes is concerned, most of the patients are landing with one of the important complication of diabetes, that is diabetic ketoacidosis. And if it is unrecognized, if not diagnosed, mind well, the patients who is supposed to get survived from the COVID-19 disease may die of this diabetic complication, that is diabetic ketoacidosis. So one should be very, very attentive as far as this particular illness, particular diabetes is concerned. As far as the management issue is concerned, most important thing in this particular patients who are having either mild illness, moderate illness, or the severe illness is monitoring and monitoring and monitoring. That is very, very important. And what is monitoring? Very simple parameters that we are supposed to monitor. We are supposed to monitor the heart rate, we are supposed to monitor the blood pressure, we are supposed to monitor the respiratory rate, work of breathing, we are supposed to monitor the SpO2, we are supposed to monitor certain laboratory parameters like say WBC, we are supposed to monitor the NLR, neutrophil lymphocyte ratio, RFTs, LFTs, the COVID profile, that means the inflammatory markers like say like say LDH, interleukin 6 and so on and so forth, ferritin and so on and so forth. D-dimer we are supposed to, which is a marker of coagulopathy, that we are supposed to monitor. ECG we are supposed to monitor, and then X-ray chest. Monitoring is extremely important in this particular patient, and monitoring how often the patient needs to be monitored. It all depends on what category of illness the patient has, whether it is a mild illness that is there, whether it is moderate or say severe illness. When it is mild illness that is there, heart rate, blood pressure monitoring is required daily, respiratory rate monitoring is required 2 hourly. The laboratory investigation like say CBC NLR is required at the baseline, COVID profile inflammatory markers are required at the baseline, D-dimer is required every 3rd day or 4th day, ECG at baseline, and as the disease process progresses from mild illness to moderate illness to severe illness, the monitoring frequency goes on increasing. For example, if it is severe illness that is there, the heart rate and blood pressure has to be monitored every 4 hourly. The respiratory rate, work of breathing and SpO2 has to be monitored continuously. The CBC NLR, neutrophil lymphocyte ratio, has to be monitored on daily basis. The inflammatory markers at least every 2 days has to be monitored. The D-dimer at least every 2 days has to be monitored in this particular individual and require. Why this thing is required? Why this monitoring? This is a very dynamic disease that we are coming across. What we find on admission is a mild disease. After 2 days you will be finding that the patient is progressing into a mild, moderate type of disease. On very 5th day or 6th day we are finding that the patient is landing into a severe form of the disease where inflammation, thrombosis is going to be there, dysfunction of the major organs, many organs are going to be there, and at a particular given period of the time we are supposed to identify this particular state and we are supposed to target that particular whatever abnormality that the patient is developing. So this monitoring is very, very important. Now, as far as the treatment modalities are concerned, what are the treatment modalities? Those are available with us for treating this particular, to have a better outcome in this particular individuals. Importantly, as I told you, the lung is getting affected, there is ventilation perfusion mismatch is going to be there, hypoxia is going to be there, SpO2 is low in this particular individuals. And if you ask me which is the best, which is the most important drug that needs to be given to this particular individual is nothing but the oxygen. I will put it at the top of the drugs that we are supposed to use in this particular oxygen, and oxygen is very, very important. And giving the oxygen by the prongs, the simple face masks or non-rebreather masks, or say NIV, or sometimes these patients they require invasive ventilation. And I'll just one sentence here as far as the invasive ventilation is concerned. Those patients who are having severe illness, those patients who are having ARDS, those patients are having a PO2 FiO2 ratio of less than 150, one should not be getting delayed as far as the intubation and mechanical ventilation is concerned in this particular individuals. What we used to do something like say 6 months ago was the high flow nasal cannula used to deliver oxygen in this particular patient. But nowadays with the research it has been found that the high flow nasal cannula, one should not attempt to give oxygenation through this particular thing, because high flow nasal cannula is going to give almost from 30 liters to 80 liters of the oxygen that can be given. That is going to be much of waste in this particular individuals, because 80 liters of the oxygen may not be going into the lungs, that can be wasted, and we know that the oxygen when it is going into the the environment, some mishap that can be happening. That's why nowadays this high flow nasal cannula strategy for giving the oxygenation is not being practiced nowadays. As far as the oxygen delivery is concerned, important thing I think somebody must have told you in detail about this CAR protocol that everybody should follow. Let it be a mild illness, let it be a moderate illness, let it be a severe illness, let the patient be on simple reservoir bag mask, let the patient be on NIV, let the patient be mechanically ventilated. What is required is the CAR protocol. CAR protocol is nothing but the COVID awake, when the patient is awake, repositioning, proning protocol. That means the patient has to be given different positions. It is possible to give simply very easy in a patient who is awake. That means the patient has to be given different different positions. And mind well, positioning is very important in these particular individuals. Why? We have found out that giving a particular position, left lateral position, right lateral position, the patient is given a semi-reclined position or prone position is given, I tell you, the SpO2 dramatically goes up by almost 10 to 15% in this particular individual, and oxygenation is going to be really good. This CAR protocol has to be followed. I will not be going into the details of this particular CAR protocol. Somebody must have told you in detail about this thing. So this is one strategy, oxygenation.